It's great to welcome to the program today Dr. Aaron Carroll, who's a professor of pediatrics at Indiana University School of Medicine and the Regenstrief Institute. I hope I'm pronouncing that correctly.
You are.
Who writes about health research and policy at the New York Times and his blog, The Incidental Economist, and has a YouTube show on these topics called Healthcare Triage. So great to have you on today.
Thanks for having me.
So let's start our conversation about evaluating different systems of healthcare and paying for healthcare, maybe by establishing how we would measure how well a system functions. What are the key things that we should be thinking about? Are they availability of care, quality of care and outcomes, the cost per capita? Like, how do we even establish the guidelines for figuring this out?
So we care about all of those things. So whenever we talk about a healthcare system or any kind of healthcare reform, I always like to frame it in terms of what some people refer to as the iron triangle, that there are three aspects of a healthcare system you always need to think about. How much does it cost? What's its access? Like how how can you get the stuff that you want or need? And then what is the quality that it produces? What makes it an iron triangle is that you can make any one, maybe two of those things better, but it often comes at the expense of the third. I can make a system that's cheaper tomorrow, but then probably it's either going to be less quality or there won't be as much of it. I can make a system universal tomorrow, meaning everybody can have everything they want. Again, that's going to cost more or probably quality will suffer. And I can give you the best system in the world, but then again, that's going to cost money or access is going to suffer in some way. So the problem is that we are always looking for a silver bullet that does all three of those things at the same time. It's just not going to happen. So most healthcare reform that we want to consider, we have to say, what are we trying to achieve and what are we willing to give up in order to get there? What are the trade-offs? We don't engage in that. Now, within those three domains, there's lots of ways to measure a healthcare system. With respect to cost, is it public cost or private cost? How much is out of pocket? How much are premiums? How much would you still have to pay even after that? How much should come out of taxes? It gets very complicated. But the United States is an incredibly expensive system, no matter how you break it down.
Yeah, I want to get to that in a second. I mean, one of the things that I recently read Uwe Reinhardt's latest book, where when he talks about the cost, he says something which makes sense, but I think is often not in the conversation that happens, at least in the media, about healthcare, which is that, as you point out, there is some total cost, and that can go up or down. What is the total cost to treat the average person in a year? And then oftentimes what we're really debating is actually how should that total cost be divided from the population? In other words, should we tax richer people more in order to pay, or so on and so forth? Is that a part of the discussion that is maybe not spoken about in those clear terms sometimes?
I think it's part of, but it's not even all of it. Part of it is that we think we have a very private system, and we do compared to some countries, but still about 2/3 of healthcare spending in the United States is what we would consider not private. It's public, meaning that it's Medicare, it's Medicaid, all of which are taxpayer or some other way, government run. It's the VA. It's everyone that works for a public institution but has private insurance, like me. I work for Indiana University. It's a state. You're all paying my salary and taxes, and you're all paying my health insurance. Even though I have private health insurance, it's public taxpayer money, which is paying for it. And charity, when you add all that up, it's like 2/3 of healthcare spending is already publicly financed in the United States. That's almost more per person than any other country pays total. And then on top of that, we still feel like we're all privately paying way too much money for premiums at our jobs. And even on top of that, we feel like we're paying way too much money out of pocket when it comes to co-pays and deductibles. So no matter which way you want to measure how we're spending and what the cost of care is in the United States, it's just unbelievably high. Especially, I mean, Uwe would be the first person to tell you, rest his soul, but it's the prices. It's not even just how much are we consuming, but it costs more per unit in the United States than anywhere else you could possibly imagine. And so our costs are just through the roof. And of course, everybody wants that to be less or lower, but you can't do that without sacrificing access or quality likely in some way.
So let's get into that.
You also get to it because it's so much of our economy.
Right.
And if we drastically reduce healthcare spending tomorrow, we would instantly be in recession and or depression.
Yeah, so that's another really interesting thing from Reinhardt's book, where he says if you actually, spending in healthcare is jobs
Yeah.
in a very practical sense. And we
Yes.
have this idea that if we reduce spending but get rid of extraneous things like medical billing and insurance fraud investigations, that it's all, okay, some people will have to find new jobs. But there is a very direct link between total healthcare spending and employment.
Well, again, it's like when we say waste, it's not money that we put in a pile and burn. All of that waste is another person's income. It's paying for stuff and people and jobs, and not even just, drugs, but the people that work at the drug company, the people that clean the offices at the drug company, the people that pave the lots outside of the drug. It's 16, 17, 18% of GDP in the United States, meaning about what? 1/7, 1/8 of our economy is healthcare. If you say tomorrow, let's instead of spending 18%, let's spend 16%, we just drop GDP by 2 percentage points, we're in a depression.
Right. So along
it.
those lines, I believe Medicare for all would be a much better system than the one we have. At the same time, I have looked into enough of the specific proposals that I see what may be a problem with some of the plans for how to pay for it. And I want to see if you agree with me or where maybe I'm getting this wrong. It seems to me that most of these plans assume, in order to make the numbers work, a drastic reduction in healthcare spending per capita in the United States that would put us, depending on the plan that you look at, in line with maybe Canada or Australia. And I have not seen a good defense of how that's going to happen. Aside from whether it would be good or bad, we can debate that part. I understand that if you eliminate some of the, quote, waste from the multi-insurance billing system and different things, you'll reduce cost a little bit. But I don't see how it gets reduced so much. Is that a fair critique of some of the plans for how to pay for it, or am I maybe missing something?
Of some of it, yes, but I would say it's even a little more complicated than that, because again, I would talk of it in terms of trade-offs like we were at the beginning.
Sure.
So single-payer healthcare, which is what Medicare for all is, a perfectly viable way to improve access. That's what it would do. It would get us to universal health. So at that point, you'd say, well, what's the trade-off? Are we going to sacrifice quality, or are we going to spend more money? And we could absolutely spend more money, and everything would be fine. But if we're not, then we have to say, well, then what will the trade-off be? If we're going to significantly reduce spending at the same time that we're massively increasing access, you imagine that quality has to suffer in some way. But the broader picture is exactly what you said. Like, there's no magic to this. Single-payer healthcare systems are not inherently cheap. They're cheap because they can use their single-payer market power to force every provider and purveyor of healthcare to accept lower reimbursement. And so that's where the magic comes in. Medicare often reimburses less than private insurance because they just have all the patients, and they can turn to providers and say, we've got all these patients. If you want to make a living, you have to accept the insurance the way that is. Theoretically, if everyone was on Medicare, then the government would have enormous power to say, everyone's going to have to accept less reimbursement. That's how it's all going to function. Well, there are trade-offs to that, be it through innovation, be it through what people are willing or able to provide. The idea that everyone is going to continue to operate at peak performance for less money is not realistic. And again, we can say, oh, well, we'll just take it out of fraud and waste. That's still somebody's income. That's still somebody working. There's no magic solution. So Medicare for all is a perfectly viable way to achieve universal coverage and theoretically to use market power to reduce overall healthcare spending, but there's going to be trade-offs.
So now a defender of the Medicare for all system would hear you talking about that and say, well, there's a combination of things there that would go into this. On the one hand, there is a stimulative, even though, yes, a reduction in total cost is a reduction in jobs, the stimulative effect for all of the end users who no longer are spending as much money out of pocket, if you believe those estimates, and also are not at risk of a bankruptcy because of unpredictable healthcare spending, all of that money is going to have a much more stimulative effect being spent at businesses, for example. That will increase government revenues. And therefore, it's all sort of going to work out in the end in a way that is relatively neat and tidy. So, what do you think about that?
I think it will work out in the end, but I think it's because Americans have no appetite for cost control. I think what would happen is that if we passed the Medicare for all, what would happen is the system would just cost much, much, much more money. Because we could theoretically use this market power that we have in Medicare right now to curtail or hold down Medicare spending, and we don't. The government just keeps spending more and more on Medicare to where you have politicians arguing Medicare is going to go bankrupt, it's spending too much, and no one does anything. That's what I think would happen in the whole system. We just won't.
When I read the analyses, it seems as though the access piece may well be as it's expected to be. The quality of care piece, if managed correctly, may well be. It seems that it's just going to cost more than most of the plans are accounting for. And maybe that's okay as a decision that a country can make.
And that's where it's like, if somebody said to me, like, well, then what would you? It's like, I believe we have plenty of appetite to spend a fortune on healthcare. Given that, there are better ways to do this that would provide higher quality and better access for the enormous amount of money we seem willing to spend. I think deep in people's hearts, that's where Medicare for all would wind up if it was passed, is that it would achieve universal access. In order to avoid real problems in quality, we would just keep spending more and more and more money. And because we have no appetite to say no, it would just not hit the budget projections that people think. And then how would we pay for that? I think likely if someone actually had the political power to get Medicare for all through, it would be on the backs of things like wealth taxes and trying to squeeze more money out of the people at the very high end.
Yeah, I mean, that's part of it. There's also this political reality where there's never a question of how do we pay for this war or those weapons, but it's a debate here. And I think that's a reasonable critique.
Yeah, and I think that's why if Medicare for all was to pass, that's how it would work. It would just be very, very expensive. I don't think we have much of an appetite for saying no to individuals for healthcare stuff that they have, no matter if it works or not. I don't think we have much of an appetite for really impinging people's ability to get what they want in terms of access as quickly as they want. Nor are we going to suffer much in terms of quality decline. So we'll just spend a lot. And we've been doing it for a long time, and that's what we would do. And I think the arguments would be, if it were to pass, exactly what you said, that we don't seem to worry about how much the war cost or how much the tax cut costs. Why are you all screaming about how much the healthcare costs? Everyone's getting it. They're feeling better about it. Let's just spend a ton of money.
Now, if it were just up to you, because you've looked at so many systems, you've looked at European systems, there's the system in Singapore, which we've talked about before, which is very interesting. Do you find that there is some other system that might be better suited for the United States specifically?
So this is what about 2.5 years ago, we did this thing at the New York Times where we actually, we picked 8 countries' healthcare systems, and we held a tournament, did a bracket, and let both experts and the public vote. And in the end, it came down to a battle between France and Switzerland won. And I think that's a reasonable call. Switzerland has a healthcare system which is universal, and it is entirely private. There is no Medicare or Medicaid-ish kind of thing. It's entirely private, well-regulated, mostly nonprofit health insurance, not coupled to jobs from birth to death, with a sliding scale subsidy for those at the low end of the socioeconomic spectrum, so subsidies to help people buy it. They achieve remarkable outcomes. They have pretty high levels of cost sharing, which we seem to believe in. And their costs are high compared to most of the world, but not to us. And it's great. And it's entirely private. There was a plan not that long ago, perhaps a little more than a decade ago. It was called Wyden-Bennett. It was Ron Wyden, who's a Democrat from Oregon, and it was Bill Bennett, who was a Republican from Utah. So it was a totally bipartisan plan. And they had co-signers from both sides of the aisle. And it was this. It was birth to death, exchange-like insurance, totally private with subsidies or tax credits, uncouple it from jobs. Very Switzerland-like. There was a time in the United States when that would have been the good compromise solution. But in the heat of the ACA and all the political ramifications and partisanship, it got crushed. Bennett got run out of office. No one will touch that. But I personally think that there's probably more of an appetite for that kind of tightly regulated private insurance that could be marketed as a compromise-ish type solution for America that would still allow for, still not government running it as much as, say, a Medicare for all would be, and a perfectly viable way to achieve universal coverage.
That's actually both the French and Swiss systems are ones that we've talked about extensively.
Right.
Interesting to hear that. We've been speaking with Dr. Aaron Carroll, who's a professor of pediatrics at Indiana University School of Medicine. Make sure to check out his YouTube program on these topics called Healthcare Triage. Thank you so much for your time. I really appreciate it.
Anytime.